Hello, future doctors. How are you all? Welcome back to Medstep's YouTube channel. So today we are going to discuss about one of the most important topic that is in general surgery series, that is peptic ulcer disease. Now, before going into definition, you must understand this clinically. Every patient who comes with burning epigastric pain, especially related to meals, should make you think of peptic ulcer disease until proven otherwise. So, without time waste, let's start our peptic ulcer disease lecture. So, if you are seeing this video first time, so please, if you didn't subscribe my channel, please like, share, and subscribe. So every day we are uploading one general surgery series like important topics. So if you want to learn, you can watch our videos, everything. Okay. So without time waste, let's start. First of all, peptic ulcer disease. What it means? Peptic ulcer disease is a mucosal break. That means inside the stomach we can see one mucosa. That mucosa will break if greater than 5 mm of mucosal break means in the stomach or duodenum, and that penetrates through the muscularis mucosa caused by imbalance between this we can see the peptic ulcer disease. Why? Because of the mucosal will break because of more amount of acid secretions. Okay, so we have some aggravating factors and relieving factors in peptic ulcer disease. Okay, so if you're seeing here, this is stomach with peptic ulcer. So the main common cause will be like Helicobacter pylori infection. Okay, so this is the things very important. So next you can see here, that is you can see here, that is healthy stomach. In this healthy stomach we can see the PUD means peptic ulcer disease means you can see in stomach and duodenum. So these are the things main important. So what are the main aggressive factors causing this peptic ulcer disease means? That is like uh, we have some aggressive factors, that is acid and pepsin, and we have one bacterial infection, that is H. pylori and NSAIDs. So these are the aggravating factors of our peptic ulcer disease. And we have some protective factors, that is like mucus, bicarbonate, prostaglandins, and mucosal blood flow and everything. Okay. So first of all, what is peptic ulcer disease? Peptic ulcer disease is a digestive disorder caused by the erosion in this mucosa. You can in muscularis mucosa you can see erosions of the mucosal lining in the stomach or small intestine like duodenum, like first part of the duodenum. And peptic ulcer disease also known as gastric ulcer. Okay, so these are things very important. Next we can see here, this is the peptic ulcer. So I already told, in stomach you can see these images here and here. Okay, so these are the peptic ulcer. It will look like this. So next we can see here one historical background. These are the two scientists, two doctors, the first described in 19th century. What they found in historical background, we can see acid peptic disease. They first found, who is this people? You can see here, this is Robin Warrens, and this person we called Barry Marshall. Okay, so these are the two doctors discovered the H. pylori. Okay, so in 1982 they discovered this thing. In 1982 they discovered the H. pylori, and along with that revolutionized the treatment for like antibiotics replaced only acid suppression. Okay, so these are the things very important. This is the history background. So now you can see here, this is the main peptic ulcer disease, one of the most common surgical outpatient diagnosis. So major cause of, we can see in severe cases will become major cause like upper GI bleeding and perforation, peritonitis, and gastric outlet obstruction. And this is very high exam weightage in FMGE, NEET PG, or USMLE. So, why every surgeon, every medical student must know this peptic ulcer disease? Because peptic ulcer disease is not just medical, it becomes surgical in emergency cases. So, sometimes you can see bleeding ulcer. So, if endoscopy failed means then we have to do surgery. Sometimes you can see perforated ulcer. We have to do emergency laparotomy. Next, we can see obstruction. We have to do gastrojejunostomy. So we have some high yield important points, that is peptic ulcer disease means you can see in two different sides. One is gastric ulcer and duodenal ulcer. So whenever in gastric ulcer you can see here, and duodenal ulcer means you can see here, okay, in duodenum. So the most, how you can differentiate means duodenal ulcer means the pain relieved by food. After eating food, the patient pain will reduce. If you are suspecting gastric ulcer, you have to suspect the pain. The patient will get pain worsened by food. Whenever they are eating, they will get pain. So that is pain worsened by food. Next, we can see that is most common cause of peptic ulcer disease, that is H. pylori. Okay, and most dangerous complication of peptic ulcer disease, that is it can cause perforation, because the muscular mucosa will break and it will damage and it will go deep and the perforation will go out. So that's why we call the most complication will be like perforation. So what we have to do, the gold standard test is, that is upper GI endoscopy. So these are the high yield points. Okay, before going too deep into this topic, we have to understand the surgical anatomy. So little surgical anatomy we will discuss. Okay, you can see here, this is the stomach. So in the stomach, we have some parts, that is fundus, cardiac, body, and pylorus. Okay, and antrum, pylorus and antrum. So in duodenum, you can see here, this is duodenum. In duodenum, you can see this is first part of the duodenum. That first part of duodenum we also known as, that is duodenal bulb. So the most common ulcer site. This is the most, first part is the most common ulcer site, that is we call duodenal bulb. And we can see another one like second, third, fourth part, that is, but that part is not important in peptic ulcer disease. That's why we are not going deep. Okay, so these are the little histology part, how that what are the layers we can see in stomach. And this is the lesser curvature in gastric mucosa. This is the most prone ulcers you can see in lesser curvature. Okay, so in surface anatomy, if any patient getting with the peptic ulcer disease, the patient, they will get pain in epigastrium. That is the most common pain site. In duodenal ulcer, we can see, this is, for example, this is umbilicus. Okay, so we have, right, like this, we have some quadrants. This is we call right hypochondrium, left hypochondrium. This is epigastrium. So if any patient have pain in um, gastric ulcer, the patient will get pain in this epigastrium region. Okay, they will get pain in this epigastrium region. If patient have duodenal ulcer, the patient will get little right midline. So the patient will get pain in right midline, means this spot they will get, the patient will get pain. So that is we have to suspect patient have duodenal ulcer. So next, very important, that is vasculature of the stomach. So this is the blood supply you can see here. In stomach, we can see left gastric artery. We can see left gastric artery. Along with that, you can see right gastric artery and left and gastroepiploic artery. Okay, left and right gastroepiploic artery. So this right gastroepiploic artery will give the blood, the circulation. It will provide it to greater curvature of the omentum. The left gastroepiploic will be the greater curvature and omentum. We can see here. Next, we can see the right gastric will be the blood circulation. You can see in lesser curvature. Okay, and left gastric artery will be like, will provide lesser curvature. So in duodenum, you can see here, the duodenum will get blood through superior this one superior pancreatico duodenal artery, and we can see superior and inferior pancreatico duodenal artery, we can see. While doing surgeries, the doctor can ask you, like most ulcers erode which artery, means we have to tell the patient, the doctor, we have to tell that is gastroduodenal artery, GDA. This is very important because of ulcer, because of erodation of the ulcer, the patient will get this gastroduodenal artery. This artery will become rupture and it will cause more amount of bleeding, that is massive hemorrhage. So that's why this gastroduodenal artery is GDA is very important in surgical case. Okay, this is the blood supply. Next we can see that is venous drainage. In venous drainage, whenever the total stomach will drain into the portal vein system, so PVS, so portal vein system, the venous drainage we can see. Next we can see that is lymphatic drainage and now supply of the stomach. So we can see some lymphatic drainage, that is the stomach will drain to celiac nodes. So these are the celiac nodes, and we can see pyloric nodes. So celiac nodes and pyloric nodes is the main lymphatic drainage of the stomach. We have different types of nodes, but if you are suspecting any cancer, that time we can see like a Watchow node. Along with that, we can see if patient have any gastric cancer and everything. That time we have to suspect this type of importance of the lymphatic drainage. So next we can see here, that is we called nerve supply of the stomach. So this is the nerve supply of the stomach. You can see here the nervous system we can divide into two different parts, sympathetic and parasympathetic. In parasympathetic, you can see first nerve, that is vagus nerve. Okay, this vagus nerve is very important because this vagus nerve will increases acid secretion. It increases acid secretion. Okay, so that's why this vagus nerve is very important. Next, we can see sympathetic. In sympathetic nervous system, we can see that is T5 to T9 will be like we have pain fibers. What fibers? Pain fibers. So this pain fibers is the main causing pain. We call greater splanchnic nerves, and this nerves will cause vasoconstriction, closing to pylorus and sensation. Okay, and these are the main important things. So in surgical anatomy, what are the things important? So this GDA, gastroduodenal artery erosion, we can see in posterior duodenal ulcer, and penetrating ulcer we can see if patient if that stomach getting penetrating ulcer is there, then pancreas will be like involved, we can see. Okay, and posterior gastric ulcers, we can see pancreas erosion. Okay, so what are the dangerous zones we have in stomach? That is posterior duodenal wall, and lesser curvature is the high acid zone. This is the lesser curvature we call. This is very high acid zone. Okay, and here we can see the muscular mucosa will be like little less. Okay, so these are the things. Next you can see here, this is the main stomach part, and these are the layers. We can see mucosa. Mucosa will get this muscularis mucosa will get erosion, and the patient will get this ulcer type of things. Okay, so here you can see some physiology. In this physiology, you can see like normal acid physiology. We have in stomach, we have some cells. The cells we call parietal cells, are also known as HCl. So these parietal cells will secrete HCl. HCl means what it means? Hydrogen and potassium and ATPase pump, you can see. So how this HCl will release? With this HCl will release because of some stimulators. What are the stimulators? You can see one is gastrin, and you can see another one histamine, H2 receptors you can see. Next we can see that is acetylcholine. In acetylcholine we can see that is through vagus nerve. Okay, some we have, these are the stimulators like gastrin and histamine and acetylcholine. These are the stimulators for normal physiology for releasing HCl. And next we can see that is inhibitory. Inhibitors. In inhibitors, we can see that is prostaglandin along with that somatostatin. So these are the very important things. Okay. And in stomach, we can see here that is mucosa. The mucosa, in mucosa, we can see that layer we call the um, mucus layer and bicarbonate secretions. And this mucosa, we can see blood flow, mucosal blood flow and rapid epithelial regeneration. So these are the in mucosa, we can see this type of protective layers and everything. So the HCl will be like acidic. So this bicarbonate will like alkalinate will become, it will maintain the neutrality. Okay, so mucus layer and bicarbonate secretion and mucosal blood flow and rapid epithelial regeneration. These are the things very important in physiology. In clinical relevance, we can see the peptic ulcer disease occurs when acid increases or protection or reduce the protection. When acid will reduce, the protection when acid will increased, the protection will reduce or both will reduce. Okay, so these are the things. Next, we can see here that is main pathogenesis. This is the pathogenesis. First of all, the patient will get first you can see here that is in pathophysiology. First one you can see H. pylori. In H. pylori, so this is the things you can see H. pylori. H. pylori means it's like gram-negative rod bacteria. What it will do? It's like it will stick with normal mucosa, and the H. pylori will cause colonization. Where it will cause colonization? It will cause colonization in antrum. After that, it will release. We can see urease. Then after ammonia. Then after it will injure the mucosa. Okay, and it will injure the mucosal injury. Then after we can see reducing somatostatin and increasing more amount of increasing gastrin. Whenever the patient getting increasing gastrin, then what it will do, it will increase acid secretion. Okay, so the toxins will release the inflammatory response. We can see inhibition of H plus detection to gastric atrium and the H plus over secretions we can see. Okay, so here what happened, the duodenal gastric metaplasia and after we can see ulcer formation. So next we can see NSAIDs. NSAIDs means including aspirin or with or without other antiplatelet agents. So in NSAID use, we can see COX inhibition. COX inhibition means you can see here, this is the COX-1 inhibition. Like what it will do, it will reduce the prostaglandins. Then after it will reduce the mucus and bicarbonate and blood flow. And you can see mucosal breakage. Then after it will cause ulcer. And it will increase more amount of acid secretion and gastric mucosa production will reduce. Okay, so these are the things. Next, toxicity in gastric epithelial cells, you can see this. So these are the things. Next, you can see that is another cause. Another thing will be like ischemia. In ischemia means the patient, we can see Joliger-Ellison syndrome. Joliger-Ellison syndrome means increasing acid secretion due to gastrin secreting tumor. More amount of gastrin the tumor will release, and the patient will get more amount of acid secretion. And we can see stress in ICU settings. In ICU settings, they are going to get too many antibiotics and everything. So that time the patient, the metabolism will become stress and it will cause more amount of acid secretion. And Crohn's disease and some cancers like adenocarcinoma and small cell carcinoma and lymphoma. So these are the things we can see in pathogenesis. So here we have some gastric protective factors. That is first one mucus that is barrier between cells and hydrochloric acid. Next we can see blood flow, that is it will remove the hydrogen ions and it supports mucosal cells. Next we can see epithelial cells, that is physical barrier and bicarbonate and buffers. Next we can see prostaglandins that is reducing hydrogen secretion and increasing mucus production. So next you can see here that is increasing mucosal injury substances. We can see acid, we already discussed this thing in physiology. Acid will be come by gastrin, histamine and acetylcholine. It promotes acid secretion in parietal cells. Next we can see that is toxins. Toxins, we can see drugs. For instance, like more amount of NSAIDs there, if any patient using like directly toxic to gastric epithelial cells and during and drugs that reduce platelet adhesions and plaques. Okay. So next we can see here that is erosions of mucosa. This erosions proceeds into blood vessels. We can see two different things. One is bleeding in esophagus, means we have to tell that patient have hematemesis, means vomiting in blood. Next, patient getting like bleeding into stomach, like blood passes through the GI, gastrointestinal tract, and it becomes oxidized by hydrochloric acid and digestion. So we can see melena. Melena means black tarry foul smelling stool, because the patient getting that type of melena and everything because of bleeding is there in upper GI. Okay. Next, we can see blood gets oxidized by hydrochloric acid but moves back into the esophagus. That time we can see coffee ground emesis. So the patient have GI bleeding, upper GI bleeding, and the patient getting coffee ground emesis. Then we have to suspect patient have um, gastrointestinal bleeding. We have like that. We have to suspect. Next, we can see here that is irritation of somatic innervation like T5 to T8. Here you can see dyspepsia and epigastric pain and nausea. You can see. Okay, so these are the things. Next, we can see here that is COX-2 inhibitors not always effective for gastroprotein protection in elderly patients and patients on NSAIDs. Mucosal erosions can be silent and asymptomatic. Okay, so these are things very important. Next, we can see here we have some causes of peptic ulcer disease. That is, common causes will be like H. pylori infection and NSAIDs, prolonged using of NSAIDs, and stress related mucosal damage. Okay, so next we can see here that is stress related mucosal damage means like smoking or stress ulcers will cause stress related mucosal damage. Next we can see uncommon, that is Zolliger-Ellison syndrome, means gastrinoma, means gastric tumor, and other hypersecretory acid states, tumors, and cancers. And we can see um, tumors like cancer and lipoma and viral infections and radiations and chemotherapy and some illicit drugs used causing vascular insufficiency. In rare cases, we can see Crohn's disease of the stomach, duodenum, and we can see colonization of stomach with Helicobacter Hale-Money and idiopathic. Okay, so next we can see that is some risk factors. These are the main risk factors we can see in. We can see some risk factors. The risk factors we can see chronic NSAIDs use and alcohol and smoking and old age and critical illness. Okay, so if any patient have peptic ulcer disease, in gross pathology we can see round oval punched out ulcer. So if you're doing endoscopy in that endoscopy, you can see punched out ulcer. Then you have to suspect patient have peptic ulcer disease. Along with that, we can see clear or clean base. You can see. Next, you can see here that is surrounding inflammatory margins. You can see in peptic ulcer disease. We already saw many pictures before in beginning the lecture. Next, we can see like microscopic and like histology. In histology, we can see necrotic debris, granulation tissue, and fibrosis in chronic ulcers. We have some types of ulcers, that is duodenal ulcer. This is the duodenal ulcer is the most common ulcer, that is duodenal ulcer. Next, we can see gastric ulcer and stress ulcer, and we can see curling ulcer. When patient will get curling ulcer with burns. Next, we can see Cushing ulcers. Cushing ulcers means the patient will get brain injury. So that is Cushing ulcers. Next, we can see here clinical features. In clinical features, if you're seeing symptoms, that is gastric ulcer. In gastric ulcer, you can see the patient will get pain worsen with food, and we can see weight loss. So that is gastric ulcer. Why weight loss? Because patient, whenever patient eating food, patient getting pain, so patient will stop eating and they will get anorexia, not getting interest to eat because of pain. So next we can see that is duodenal ulcer. In duodenal ulcer, the patient will get epigastric pain, and the pain we can see like 2 to 3 hours after meals, and we can see night pain, and the pain relieved by food. So that is duodenal ulcer. So in the duodenal ulcer, we can see mostly like weight gain patients like that you can see. Next, signs. In signs, we can see like epigastric tenderness and pallor. Why patient will get pallor? Because of bleeding issues, GI bleeding issues because of more amount of erosion and ulcer formation. Next, we can see signs of perforation. What are the signs you can see in perforation if any patient have? One is guarding. Next, rigidity. So these are the things we can see in if patient have signs perforation. So next we can see that is complications symptoms like red flags. We can see hematemesis and melena in GI bleeding and sudden severe abdominal pain. Sudden severe abdominal pain patient will get when if patient have perforation. Next, we can see vomiting. In which patient we can see vomiting means the patient, if patient have GOO means gastric outlet obstruction. If patient have gastric outlet obstruction, these are the like another causes we can give like differential diagnosis. Okay. Next, history taking. History taking is very important when patient is coming from like outpatient clinic means this history taking will guide you very like appropriate management and diagnosis you can do with history taking. So how? We have to ask some key questions like the patient used any prolonged NSAID use or smoking or smoking habits or alcohol habits and anything related with the pain like food. If the after eating food or before eating food, the patient getting pain, anything or relieving anything like that, we have to ask aggravating factor and relieving factors of the pain and vomitings, vomiting in blood, anything like that, and any black stools are there like melena. These are things we have to suspect and we have to ask. Next, physical examination. In physical examination we can see like in physical examination mostly with history taking you can diagnose the patient condition. In physical examination we have to check pallor. Why? If patient have more amount of bleeding issues. Next we can see dehydration. In abdomen we can see like epigastric tenderness and guarding. Guarding means the patient will get perforation and we can see Succusian splash means we can see this thing in gastric outlet obstruction cases. Okay, next we have some differential diagnosis. If the doctor asking, tell me this some differential diagnosis, you can tell based on the patient pain site and everything. First one, the gastritis will mimic like PUD, like the patient will get diffuse pain. Next we can see GERD. In GERD you can see retrosternal burning. So that is GERD. Next we can see gallstones. In gallstones patient mostly will get right upper quadrant pain. Next we can see pancreatitis. The patient will get pain in the epigastrium and it will radiate to back. And it will radiate to back. So this is the pancreatitis. So differential diagnosis, if anyone asking means you have to tell patient have gastritis, GERD, pancreatitis and gallstones. Next, very important thing, that is investigation. In investigation we can see here, first we can do in bedside cases we can do stool occult blood. The gold standard of investigation of peptic ulcer disease or everything, that is very important thing that is upper GI endoscopy. Next, in labs we can do in blood workup, we can do like CBC for checking anemia, and next we can see urea breath test for finding out H pylori. Next we can do imaging. That imaging will be like if you're doing X-ray, in that X-ray the patient must be like erect abdomen. Why it's erect abdomen of the X-ray means we can easily find out the patient if the patient have any in X-ray air under diaphragm, we have to suspect patient have perforation. So we can see we can do CT scan. The CT scan is the main important thing to detect the perforation and other complications. So I forget to mention, we can differentiate, we can classify the peptic ulcer disease into three different classification. Like the first classification will be like acute ulcer, chronic ulcer and complicated ulcer. Okay, so now very important thing, that is management. In management the main goal is to reduce acid secretion and eradicate H pylori and prevent complications. So we can use some drugs that is like proton pump inhibitors like omeprazole 20 to 40 milligram or another drugs also we can use. And H. pylori regimens, if you're suspecting patient have H. pylori, peptic ulcer disease, we have two different types of therapies, but first we have to follow in medical management that is triple and therapy. So triple H. pylori therapy. What we have to do here in triple therapy, we have to use that medication for 14 days. In these 14 days, first, like the pantoprazole 40 milligram BID and means 2 times per day, amoxicillin 1 gram 2 times per day, and clarithromycin 500 milligram 2 times per day. How many days we have to give? For 14 days, and after 14 days we have to continue proton pump inhibitors like omeprazole or pantoprazole like 4 to 8 weeks. Okay. After using this triple therapy, still the patient is not getting any recovery, then we have to suspect the patient have clarithromycin resistance. Then we can go with bismuth quadruple therapy. So this is 4 drugs we are going to give. Triple means 3, right? Like pantoprazole, amoxicillin, and clarithromycin. So same to same in quadruple therapy, we have to go with 4 medications, that is proton pump inhibitors as usual like before. Bismuth subsalicylate, this is the mucus protective medication. We have to give 524 milligram QID 4 times per day. Next, metronidazole 500 milligram TID or QID, and TCA means tetracycline we can give 500 milligram 4 times per day. So how many days we have to give these medications? For 14 days we have to give. In severe cases, we can do surgical management. In surgical management, the main indications will be like patient have any perforation or bleeding not controlled with endoscopically, and if patient have like obstruction, we have to go with Graham's patch repair or vagotomy, pyloroplasty, and partial gastrectomy. So first, what it means, whenever patient telling like if doctor telling like Graham patch repair, so this is the main common surgery we can see in our general surgery department. So how to do this Graham patch surgery means repair means, first of all we can see, the patient will do the surgeon will do midline laparotomy um, to access peritoneal cavity. Then after they will identify the perforation. Usually mostly we can see this perforation and this everything we can see in anterior duodenum, because this is the most common site of patient will get duodenal ulcer perforation. Mostly the GDA means gastroduodenal artery will cause damage, and patient will get more amount of massive hemorrhage. Okay, so usually we have to identify the perforation. The usually we can say in anterior duodenum. Then after we have to check the freshen edges, and we have to remove the necrotic tissue, and um, we have to do omental patch. That is, we have to place omentum over the perforation. Then after we have to do suture fixation, and we have to use interrupted sutures to avoid injuring gastroduodenal artery posteriorly. Okay, so this is the Graham patch repair. So this is the main important repair for holoviscous organ or peptic ulcer perforation patients. So next we can see some complications. In these complications we can see like hemorrhage and perforation and gastric outlet obstruction and malignancy. So if any patient coming with emergency, in emergency situation, what we have to do, first of all we have to follow primary survey like intravenous fluids, ABCDE and everything, intravenous fluids and nasogastric tube for decompression. Then after we have to start proton pump inhibitors intravenously, and we have to send the patient for emergency surgery if you are suspecting perforation. So based on guidelines, first line management, we have to do proton pump inhibitors for H. pylori eradication. If patient have more than 55 years, the if patient getting symptoms, we have to do endoscopy. Okay, so so in ASCII stations, if you are in general surgery department, the doctor can ask endoscope. They will give some endoscopical picture with gastric ulcer or duodenal ulcer. We have to know how to interpret that thing, like the edges, the ulcer perforation, the bleeding is there or not. Okay, so these are things you have to know how to interpret it. Okay, so For example, when I did general surgery department, that time in accidental department, I saw some patient like young males with epigastric pain relieved by food. Then we have to suspect the patient likely have duodenal ulcer, and it confirms by endoscopy, and we have to treat the patient with the proton pump inhibitors and H. pylori therapy. Okay, so in at last, I want to give some high yield points. That is, H. pylori is the most common cause of peptic ulcer disease, and posterior duodenal ulcer. If patient have means the mostly we can see gastroduodenal artery bleeding. Treatment we can use triple therapy. If triple therapy is not working, then we have to go with quadruple therapy. In that after quadruple therapy, we have to after quadruple therapy we have to go with that is if patient have perforation, we have to go with surgical management. That is Graham patch repair. Okay, so at last, in simple language, if anyone asking like in rounds, if any doctor is asking you what it means, what just tell me the peptic ulcer disease, we can tell like simply imbalance between acid and mucosal defense. So patient will get ulcers and complications, and these are the things you can explain to your doctor. Okay, so these are the things. So I already covered everything from basic to advanced level. If you have any doubt, you can ask me in comment section. So I already made many videos, many topic. I covered already many topics in this general surgery series. If you didn't watch the topics, go and watch. Okay, so we will meet in our next video. Till the time, I'm signing off. Take care. Bye.